Welcome, everyone, to Renegade Research Roundtable. If this is your first time with us, thank you for joining us. I am Isabel. I am CEO of our organization. We are a patient and caregiver-led, decentralized 501c3 nonprofit focusing on complex multi-system chronic conditions such as ME/CFS and long COVID. With this, we have three areas of focus: research that's agile and patient-centered, education to increase the number of clinicians treating us, and practical advocacy around barriers to care. Our work is made possible by our wonderful team of volunteers who move the wheels of our organization. Most of us have a personal interest in advancing research and care of these conditions. To stay in touch with us and hear about upcoming events, please subscribe to our newsletter and follow us on social media. We'll be sharing those links during the presentation. And today we will have a presentation by Dr. Smith, and Elly will be introducing us shortly.
Thank you, Isabel. I'm Elly Brocious, and just as a reminder, today is Stephen J. Smith talking about orthostatic flow syndromes and what we could do to help. We have some special panelists, one who's very dear to me. Peter Rowe is probably our most famous one for our community. He's done 4 roundtables with us already, and he always mentions that some patients have had vein problems and that can be treated, and he gives us examples. So at our last talk, we asked way too many questions of him about this, and he suggested we bring his co-author, Steve Smith, to come speak. Dr. Rowe, please tell us a little bit about Steve Smith.
Okay, thank you, Elly. It's a real pleasure to introduce Dr. Smith, who I think I met about 5 years ago, Steve, at the beginning of the pandemic. You are going to see very soon that he is a true renegade researcher, a maverick who's been tackling and really upending a lot of the conventional wisdom surrounding the issues of pelvic pain in women. And along the way, he has uncovered a number of important associations between connective tissue laxity, which we know is a big problem in our community, pelvic venous insufficiency, and then problems that would seem to be quite remote from the pelvis, like migraines and POTS. And so he's going to be presenting some of the data on the outcomes of these treatments. By way of background, Steve graduated from the Wayne State School of Medicine in Detroit. He did his internship and residency in radiology at the Henry Ford Hospital in Detroit, and an interventional radiology fellowship at Northwestern. He has been a very active clinician from 1984 until his so-called retirement in 2020. He was in private practice interventional radiology in the Chicago area, involved in clinical trials, and got very interested in the care of women with uterine fibroids, doing one of the first embolizations in humans, and also apparently in a gorilla. He more recently has turned his attention to improving our understanding of the wide range of symptoms that can be improved by the recognition and treatment of pelvic venous insufficiency. He is also a music aficionado, a Renaissance man, and as you will see, a very dynamic and engaging speaker. So without any further time, Steve, take it away.
Wow. Okay. Thank you, Peter. So can everybody see the slide that's up there? Orthostatic flow syndrome, picture of a belt and all that stuff. Yes. Okay. Thank you very much for that introduction, and I'll launch into it. So orthostatic flow syndrome is a made-up name, all right? I think it's a good name, and it's something that you can use as a basket to describe this sort of sprawling interconnection of stuff that veins are and blood return are connected with. I think compression syndrome, people use that. I don't know if that covers dilated veins. Somebody else wrote me and said, oh, we should call this dilated vein disease. And I said, no, because it's partly obstructive. So I just made this up as a basket, and probably no one will use it, but it fits, I think. So on this slide, what you see is the way that physiologists and people who are caring for the ME, CFS POTS community, how they've been measuring blood flow and looking at blood flow. So they've known for a long time that there's poor blood volume in the upper body in these patients, a lot of the patients, and they've been able to sort of map out uh, an increased sympathoadrenal response, which sounds like fight or flight to me. And then that's sort of linked up with all of the different names of the different subconditions. Brain fog, people got low blood flow in their brain, and also ME/CFS. So we are plumbers, and this is a vein blood flow problem. So is there some role for us here? I don't know. So, but I'll just, this is my disclosure slide, and just go on. I want to thank the people that have, some of the people that have helped, and Dacre Knight and Peter Rowe, certainly, who are here. Also, this is Mike Sikla, and the big questionnaire we use was written by him, and I helped him. This is Brenda Chen, who was a medical assistant in our office, now a third-year medical student. Luke Sewell is the leader of our group, and this is in our clinic. Neil Karana helped out a lot, and this is my sister, Holly Smith, who was a PhD and did the statistics, and she used to teach statistics in college. So anyway, here's an interesting article, 2006, Embolotherapy for Pelvic Congestion Syndrome Long-Term Results. Tony Venbrooks, who to me is like a god of this stuff. He's really brilliant guy. And he published, this is one of the best papers showing pelvic pain went from 7.6 VAS to 2.9 after you just embolized pelvic veins. And look who is one of the authors, Peter C. Rowe. This comes from Johns Hopkins. And I actually went to Johns Hopkins to learn how to embolize varicoceles many years ago in 1985. And this is sort of like female varicocele. So what is the reason for us to think that this is worthwhile? Okay. So these Van Kampen and Visser showed that MECSF gets worse when you tilt people. Brain blood flow is reduced, even if blood pressure is normal. Zaumener showed fibromyalgia pain levels are linked to sympathetic activity, which is the reaction to not enough blood in the upper body. Tilt, increased pain and low blood pressure in fibromyalgia. And Sky Kui showed that if you dump blood back into the vena cava, it causes decreased sympathetic output. So there's a lot of stuff to make us think that just, experimentally and physiologically, we may be on the right track. So I don't know. I think we're calling this chronic pelvic pain of venous origin now, pelvic congestion syndrome, all the stuff you could call it. So chronic, what is the definition? Chronic, more than 6 months pelvic pain in women, non-cyclic, but worse around ovulation or menses, caused by problems, venous insufficiency in the pelvis, occurs in the upright position, gets worse during the day. It is relieved by lying down, but not immediately. So it's orthostatic in nature. See, it's part of the orthostatic club. So narrowing of the left renal vein, the left iliac veins, often associated with varicose veins in the leg, more common in multips because multiple pregnancies smash on the veins and hormones, and it's frequently misdiagnosed. So in this sort of general article about pelvic congestion syndrome, they say, well, 60% of cases, gynecologists can't figure out what is causing pelvic pain. But 30% turns out had pelvic congestion syndrome, as we used to call it then, as the cause. So maybe you could extrapolate that 5% of women might have pelvic vein pain in the USA. That's a lot of women who go to the gynecologist who say, we don't know why you have pelvic pain. 3 billion a year is spent on chronic pelvic pain in the USA, and there's a pelvic pain center on every street corner almost. But look at this. Here's a review in JAMA, and it's written by people who are on the board of the International Pelvic Pain Society, the experts. I mean, they are the experts. And this entire article, which is very exhaustive, you'd think, doesn't contain the word vein. And so, and this is not that long ago. I'll have to look and see when, but the point is, gynecologists are studiously avoiding this. So why? If you look at some of these articles, Enigma, pelvic pain, there was all this pelvic pain that they couldn't find. They would open up women and look, and they couldn't see the veins. So they thought some women might have veins and pain, but other women had pain and no veins, or veins and no pain. So they made the decision that these things weren't related, and that was it. And that stuff went into the textbooks of OBGYN, around the 70s. So, and then, it just sort of gets updated. So the main guy was this guy, Atlee, who, said it was diagnostic garbage, and these guys didn't believe it. They were the big names. So that was it. Jump forward to 2016, and this is from American Family Physician, and this is atrocious. So this comes from the world of pain doctors and gynecology. So here's a flow chart. A patient has chronic pelvic pain, known disease process treated. Unknown cause of pain. Remember, 60% of patients are going to go here, right? Well, just give them pain drugs. Okay. Inadequate relief. So suspect neuropathic pain, underlying mood disorder. Then yes, psych drugs. No, different psych drugs. Okay. But cyclic component. Okay, hormone therapy, that might work. Inadequate relief, go to A, psych drugs. That's what family doctors were told to do with chronic pelvic pain. Nothing about veins. So this Turkish doctor, Soysal, wanted to test some drug on women who had pelvic congestion syndrome. So he had to find out who really had it, and he did the only or best study, and he tested for everything. He did surgery, so, adhesions, endometriosis, blah, blah, blah. 31% had pelvic congestion only, but 12% of patients with other pathology also had pelvic congestion, abnormal veins. So some of those people, I'm sure, had pain from the veins, and maybe they had, I don't know, something else. But next commonest was endometriosis. So really, endometriosis and pelvic congestion syndrome are right up there. And there are other studies that show that pelvic pain patients, only 20-some% of them have endometriosis. But everybody knows endometriosis. So there are a lot of studies from around the world. And, the problem is that interventional radiologists are, we're like, a lot of us are sort of at an outpost. So we do studies, we end up with small trials, and they're all positive. We don't have a large RTC, and so we can blame ourselves for non-acceptance, because we're really going to have to prove it to the people who are the custodians of women's pelvises, and that's the gynecologists. But what I see is that these women are really pitiful sometimes. So how do I diagnose it? Gravity-related pain, worse as the day goes on, burning, aching, left-sided, feels like a bowling ball pressing in the vagina, and a little worse during ovulation or menses. But when they say non-cyclic, they mean it's also present at other times. So, oops, let's see. And then these things, varicose leg veins, vaginal pain, maybe multifarious and dysuria, hemorrhoids, hip pain, a lot of other stuff. If they're young and have no kids, maybe they got joint hypermobility. You got to press over the left ovary where you think the left ovary is. If there's exquisite pain there, that's supposed to be fairly sensitive and specific. You got to look at the vulva with the patient standing up, at least externally for prominent veins. And a lot of gynecologists do miss that. And then you can check arms, legs, and all kinds of things. And we, do a Beighton test. This would take me 3 minutes to do and write it down and just record it so that we know what's going on. The skin part is very interesting. These patients have this a lot. That's called reticulo or livido reticularis, I'm sorry. And this is in the hand. It's really prominent. Sometimes if they have a left iliac vein narrowing, you may see just one dusky foot. The leg may not be swollen. Raynaud's, here's a point on the Beighton scale, stretchy skin. This is a good one, badly healed scars. Like that's atrocious. That looks horrible because the patient has, this is a patient who been sick for 40 years. No one ever told this patient that she had Ehlers-Danlos syndrome, and I sent her to Brooke Spencer because I ran into this gal at a party in Denver. And then there's this, and Peter Rowe showed this in his talk, these purplish, reddish, cold legs where the skin is really cold. And you press on it and it leaves a white mark for quite a while. I'm telling you, I have almost never seen this except in patients who have pelvic, congestion or pelvic venous obstruction or dilation, and some sort of dysautonomia effect. Because here's what I'm going to tell you, I think causes this. It's intense vasoconstriction from sympathetic and adrenergic combined with venous sluggish flow. And then you ain't got no blood flow at the skin, right? Blood can't get there or leave. And you get this. And it's quite impressive when you press your finger on it. I'll add that at all the patients that I've done who've had this, when they come back, they don't have this at all. Okay? All right, are they hard to detect? May not be seen on laparoscopy. And if you have a good ultrasound people who are cued in, you can diagnose it. And so maybe you can avoid all the contrast and things everybody is afraid of in this community. MRV is terrific, and CT is pretty good. We don't screen people with catheter venograms anymore. And this just shows intravascular ultrasound, which is we use when we're going in to fix something usually, or we want to make sure that we're doing the right thing. And so what this does is it measures the narrow part of the iliac vein and then a more normal part, and then it tells you what is the area stenosis. This is 74%, and this is certainly abnormal. So we've got a lot of tools. Here's a great case. So this patient had count them, 5 laparoscopies for endometriosis, and here are little implants. And so those get lasered, and then there are pictures of like a little smoking hole there. But her pain never got better. And here, look at these are veins. Now, here I can't look at this and say those are abnormal veins, but the person. So remember, the patient is in Trendelenburg, and the abdomen is filled up with CO2, and so that all tends to make veins sort of go back. You might or you might not see them, but you sure see these. Okay. So May-Thurner syndrome is a specific, painful swollen left leg and sometimes with clots and problems like that. But this is just the May-Thurner effect, you might say. So here's the aorta, and the right common iliac artery is pressing on the point where the left common iliac vein joins the vena cava. Everybody see that? And so here's the diagram, and look, here's the right common iliac vein here, and here's the right common iliac artery, and the vein is trying to sneak under it, but there's no room there. I'd say that's like 3 millimeters. So we'll say that's abnormal. And CT is useful too. I mean, if you can't have an MR. This is a CT scan, a CT arteriogram, venogram through the pelvis. And because the blood shoots down the ovarian vein, you see these big varicose veins in the pelvis, and they're very whitened up because the contrast shoots down there. This shows a stent in the left renal vein, and this looks like a diagram in a book. Stents and arteries. So with imaging, we can see the anatomy in reality. So look at this diagram and look at this. And if I tell you, what is this? Anybody answer who's not a radiologist? Total silence. Is anyone hearing me? Just
Yes.
good. Well, anyway, look, this is the left common iliac vein, the troublesome one, and here it is over here. Here's the right common iliac artery. Here's the vena cava, here's the aorta, okay? This is, pictures from a patient. Here's a diagram. So this is really cool. So we can see stuff. Now okay, watch this. This is an MRA V. And on this side, this is normal. All right, this is a normal patient, or pretty normal. You see the contrast shoot down the aorta, right? And into all the little arteries and stuff. It rapidly goes into the kidneys, and then it flows out through that from the pelvis through this iliac vein. I thought, well, maybe these are prominent, but we'll watch it again. I mean, I hope you guys think this is pretty cool, but
Yes, we do think it's very cool. Thank you.
it's cool to be able to look inside and really see what's going on. Now, this is an abnormal one. Okay, let's watch this one. And you're going to see a big, huge thing come down right at this one, I think. Oh my God, look at that. So that is reflux from the left renal vein down the left gonadal vein into a bunch of varicose veins in the pelvis. Now, if those veins look big, remember the patient's lying down. When the patient stands up and blood is just stagnant down there, things are going to start to hurt. So another thing that you can notice is, all right, it came down here, and then some of it went over here, but it tried to go up here. And this part of the left common iliac vein, this part is cut off. Do you see that? So let's watch. So we can ask ourselves, why the heck does the stuff come down the vein? And here the contrast is going up toward the heart, and in veins, it's always supposed to go up toward the heart. Is this working? Yes. Fortunately, I've got another one. All right, this different patients. Again, this should, I hope, be normal. Boom, flashes into the aorta, goes out here, and goes up the veins very nicely. See that? You can see them. Maybe there's a little dent in this vein, and here's just stuff trickling up the little tiny ovarian veins. Normal. Here's another abnormal. Boom. So right when the artery fills, this vein fills and it goes all the way down here and up the right side, okay? Everybody see that?
Yep.
So if the patient has the symptoms, the correct symptoms, not just big veins, and then they have the matching this stuff, then we can say, okay, let's see if we can try and fix it. Okay, and then, we can just do our venography and inject and stuff flows into these giant veins. Here's another, I mean, look at that. Oh, so if you look at that patient, if I tell you that this is the uterus, the veins take up almost as much room as the uterus in the pelvis laying down. Okay. Okay, so let's do a case. Um, hold on, I gotta go back. Okay, for this is the first patient who made me think something weird was going on. So nice, tall, kind of skinny woman, severe chronic pelvic pain, vulvar varices, dyspareunia, just miserable, haggard-looking women, and they all look very pale in the face because they ain't getting no blood upstairs. So a lot of bladder problems, and she was diagnosed with interstitial cystitis. She went to the University of Chicago urogyne for years and had all these. They would inflate her bladder with steroid solution because she has interstitial cystitis, which is inflammatory, right? And she just finally quit going. But when she comes in to see me, she doesn't tell me about any of this. She's only there for the boutique treatment of her pelvic pain, not her bladder problems. So anyway, she's got a lot of abnormalities which we fix. And she also, so she didn't tell us about that. She didn't tell us about this stuff, okay, which could sound like dysautonomia, but so we had, just inject the stuff into the veins, and these veins will just be gone. They'll just be gone. And so and these veins kind of go under the bladder. This is the bladder. Her POTS, 3 months later, POTS symptoms are gone, and her 12 years of severe interstitial cystitis is gone. So that's when I said something weird is going on. So then I started listening a little better, and so very soon after that, this woman, little kind of muscular, bandy-legged Polish cleaning lady, a lot of pain in her vagina, goes to her gynecologist and asks about pelvic congestion. He says there's no such thing. So he put her on gabapentin, but she cleans offices and houses, and that makes her sleepy. But she also has crushing chest pain every day uh, when she gets in the car and is driving. So coronaries are normal, puts on Xanax. She says like somebody's standing on her chest. So here's the venogram, and here you see the artery impression on the vein. See it? It looks like you put your finger on it. Do you see? And blood is trying to get around it. And here, geez, 86% is narrowed here. So, fixed it. And actually, both sides were narrowed, and she had varicose vein, did a bunch of stuff. She came back, her pelvic pain is gone, off gabapentin, crushing chest pain gone. She feels great. And so all of her doctors were amazed. And now I've spoken to her 8 years out. She's still cured of that stuff. So she had some kind of POTS syndrome, and so what's the deal? So I just spent a lot of time reading about this, and the more I read, the more I found. So what I want to know is how are the veins connected to interstitial cystitis and POTS? But what I found was that those two things are connected with a huge constellation of other named illnesses. And you're probably familiar, chronic fatigue, migraine, fibromyalgia, um, irritable bowel syndrome, TMJ, brain fog, which, is sort of its own problem, a lot of stuff. And look at how many people have this stuff. So I said, I was laughing. I said, "Oh, irritable bowel 39 million, TMJ 39 million, migraines 39 million. Is it the same 39 million?" Uh, but anyway, so all of these are related to each other. And there were several articles like this. If you look at chronic fatigue, fibromyalgia, IBS, multiple chemical sensitivities, TMJ problems, headaches, interstitial cystitis, and post-concussion syndrome, they all hang out with each other, and they sometimes they overlap 50, 75%. What? And now I think that what I'm doing is related to that. So they say, the models don't account for these occurrences. So why not name all these things a different name? But what if they're related? You know. So William of Occam guides us. If all those are of unknown cause, and if they all hang out together, then should we presume the existence of many coincidental causes? Right? I mean, it's suspicious. He also said, "Entia non sunt multiplicanda," which means entities are what can be explained on fewer principles is explained needlessly by many. Okay? This is where we go wrong, I think, sometimes. And I saw this. This 8-year-old says to his mother, "I just worry they're doing it wrong. They separate everything so we can't understand anything. Who says music isn't really math or math isn't science? Someone made categories, but the world is a mushier than that." Okay. That's Occam, little baby Occam. So I just wondered, blood return, which is, a factor in a lot of this stuff, could it be getting blocked or stagnant in the pelvis? And could that be a factor in the decreased thoracic return that the physiologists measure? So, did anybody else think this? Yes. This brilliant genius guy, Howard Taylor. So he he reviewed what he called pelvic congestion fibrosis syndrome, and he did surgery on 105 of his own patients, and they had a whole bunch of extra gynecological symptoms. They all had kind of low blood pressure. They had severe fatigue with invalidism without adequate cause. They had like nervous breakdown, anxiety, tachycardia, headaches, bowel disorders. He said they also had, constipation and diarrhea, all this other kind of POTS-ish stuff, tension, irritability. He noted at surgery there was no infection and there was venous but not arterial congestion plus fibrosis in the vessels. So he publishes in a great 3-part article everybody should read. Man, they just laughed him out of the room. But look at this. So he didn't know how these things were happening, called them psychosomatic. He didn't know what was connecting all these things, right? So he says symptoms of general autonomic disturbance. This is 1949. Nerves, loss of energy, exhaustion, and invalidism, and all this stuff is, GI troubles, gastric troubles. Anyway, so now that's 70 some years ago. And if somebody had followed up on that, man, it could be a different world. But let's jump ahead to 1998. And Peter Rowe and some other, really smart interventional radiologists from Johns Hopkins wrote this manuscript, Pelvic Congestion Syndrome in Women with Chronic Fatigue Syndrome. And this thing is elegant, it's beautiful. And somebody noticed, maybe Peter will tell us a story, that young women with chronic fatigue had a lot of them had big kind of varicose veins in their pelvis, and they did venography and everything. It was very elegant. It's rejected by JVIR, Journal of Vascular Interventional Radiology. So I blame us. We're supposed to be so cool. You know, we're too conservative, and but that's like 27 years of no progress on that one. But Peter Rowe did, pursue blood flow. He didn't just drop the whole thing. So, I'm not at a university. We don't have a research budget. My partners are looking at me funny when they look at my clinic schedule. But so what can we do? So we made a survey and sent it to members of the Pelvic Congestion Syndrome online Facebook group to see if they had other symptoms and syndromes, and got 400 responses in patients who had that diagnosis of pelvic congestion syndrome made by a physician. And then made a long questionnaire for our vein patients and gave it to everybody at 3 months and 6 months. And now there's a multi-center trial of that questionnaire. And then with our friends at Mayo Scottsdale, Grace Knudten, we did a retrospective imaging review to look at POTS patients' pelvic veins. So just briefly, wow, severe chronic tiredness was so big in these patients. These are patients that are clustered around the interest in a single problem, and it's not dysautonomia. It's pelvic pain and veins. Look at this, dizziness, passing out. Geez, this is amazing. And this is the thing, and I'm going to show we'll in a minute, we'll take a little break here. And then in a minute, I'm just going to race through all the data, and that part won't take too long. So any questions?
Dr. Rowe, do you want to tell us a little bit about that paper?
Yeah, tell us about that paper, man.
So Steve's probably read it. Oops, sorry.
I've read it.
Steve's probably read it more recently than I have, but we were looking at this group of patients from our chronic fatigue clinic, which were mostly adolescents and college-age kids, which is not, what is written about in the pelvic congestion syndrome literature. As Steve mentioned, they're usually people who've had 2 or 3 pregnancies. And some of these girls were really impaired, like they couldn't even stand up or sit up in class. One of them was on a mattress in her class because every time she sat up or stood, she had low back pain and pelvic pain. And finally, somebody thought she might have pelvic congestion syndrome. And as soon as she had the pelvic veins embolized, she went on to be a normal high school student and is now a nurse. But she was totally incapacitated, and we found that the early onset of these varicose veins in the pelvis was associated with their Ehlers-Danlos syndrome and joint hypermobility. But for some reason, we couldn't get it published, and we were very discouraged by the comments from the reviewers that this was just nothing new.
Yeah. Are you still there? Anybody still there?
Yes.
Can you get me back in there?
You're on, Steve.
Oh, okay. I'm trying to get rid of this talk and get to the next one. So we're just going to go through data. All right. So this was the imaging study. This is from 2020, and this comes out of Mayo Clinic Scottsdale and whatever, little pissant hospital I was at in the suburbs of Chicago. And this has Mayo Clinic GI people, our interventional radiology people, our cardiologists, and then my sister and Mike Sikla and me. So this was just trying to measure how abnormal pelvic veins were in people with POTS, which was easy. We just asked our cardiologist, can you give us a list of everybody diagnosed with POTS? Boom, we had it the next day by CPT code. And then we got permission to do imaging review, and so we looked at people who had had some CT scans, and that's probably what they did at Mayo. But then they also used kidney donors, supposedly normal kidney donors. But anyway, you get this kind of a thing that I was showing you before. Here's the left common iliac vein trying to sneak under to join the right, but the artery is here. And this measurement was the crucial one. I don't know if we picked 5 millimeters or something arbitrarily, and I'll leave it to others to say. Or what did we do? Oh no, 50%, 50%. So we used a reference segment. And so anyway, the POTS people had more. They had just about 70% of the POTS people had this, and the kidney donor people had 40% of them had it. And so I was mentioning to somebody here that there is a study showing that normal kidney donor patients, I mean, what could be more normal? They're charitable and nice. But if you look at their veins and see abnormal veins, there's a study where they saw they had enlarged refluxing gonadal veins, which is associated with, pelvic congestion syndrome. If they had that, then, on the normal evaluation to donate their kidney, then nobody had asked those people if they had pain. If you ask them, 60% of them did have pain. Get it? So the normal controls may not be normal. But anyway, so that it worked out that the p-value was pretty good there. So that was the first thing. The next thing was, remember I made that, Mike and and Neil, I think made I made a survey in an hour, and then I could put it on this website, Pelvic Congestion website, and we got a lot of information out of that, and Peter Rowe's on that article. And so what I did here, and it's not like this in the paper, but I took all of the symptoms that the patients had and I just ranked them from the most common symptom down. And so pelvic heaviness, that makes sense for people with pelvic congestion. Their veins are all filled with blood, and that was 90%. Abdominal bloating, that's really an IBS symptom. Pelvic pain with upright, yeah, low back pain, that does go along with veins. Hip pain, weird. 71% did have severe chronic tiredness. Pain after sex, yeah, that goes along with having bad veins in your pelvis. Dizziness, heart flutters, POTS type symptoms, 61%. Vaginal pain, okay. IBS type symptoms, that was just another. The questions seemed duplicative, but it's hard to explain. They were phrased as either symptoms or syndromes. Excessive gas, IBS, problems with urination, pain frequency, that's interstitial cystitis. So as we drop down here, heavy menses, that's actually interesting. Heavy painful legs, of course, bad veins, right? Migraines, almost half. That goes along with, a lot of this stuff. Brain fog, 32%. So this is way before COVID. We were asking people if they had brain fog. And I think this was all completed before COVID. Excess sweating, hemorrhoids, and loose ligaments double jointed. Well, 20% of them said they had that. Well, I think that's pretty interesting. So we have an isolated group of people that have pelvic vein pain, and they got all this other stuff. And they had actually been complaining to each other in this sort of chat area there. And since my patient runs that site, I got to sort of go and see, and I realized that it was like they were like a POT syndrome bunch of people or some other thing. So then we used that big survey on our own patients, and we ended up with 45. And then we we looked at IBS and it was like, maybe a little better using a canned survey from or canned criteria from the GI world. This is from the urology world, PUF. And then the OHQ, which is a validated orthostatic intolerance survey. You can say that people who have a score greater than 6 have a clinically significant orthostatic intolerance. And you're all, maybe I can move you all over here. So walking into the clinic, our pelvic vein pain patients, 49% of them were over that line. That means 49% of our vein pain patients had clinically significant, by definition, orthostatic intolerance symptoms. After we fixed their veins, that dropped to 13%. And that's pretty amazing. The interstitial cystitis, quiz just sort of reversed. It was 64-35 and then it became 35-65. But still, this is an improvement. And this is only at 3 to 6 months. We couldn't go further because then, COVID intervened. So we gave everybody a Beighton test, and 56% of these patients had general joint hypermobility. 21% had previous former diagnosis of EDS. So that's when we figured out that these things are associated. We had always wondered, I know I talked to Brooke about this a long time ago, back in 2018. We had always wondered what was wrong with these veins that they became so stretched out, okay? And because I had a couple of patients that had this, a bell rang and I started asking people. So turns out this makes your veins stretchy, okay? And I'm pretty sure of it. So it turned out that the normal thing that stretches out your veins or narrows them or wrecks them is pregnancies, and so if you're 2 or 3 pregnancies, but sometimes we saw people had this who had no pregnancies and were very young, and a lot of them have something wrong with their collagen. So this is interesting stuff. We're putting stuff together, I think. And now, God, Brooke is really putting stuff together. So next, we took the same 45 patients and we made a list so this survey had 65 questions. So we looked at which questions somebody could come in the emergency room with this problem. It might be anxiety attack or palpitations or whatever. And so ones that had ICD-10 codes. And then we looked at those and tried to track them. And then we took some of them and we tried to see if we could bundle them into syndromes of unknown cause. All right. We had all this data, 700,000 data points. So here's a very interesting one, anxiety attacks. So I think everybody who deals with these people knows that they get panic attacks. And I'll just say this. One of my friends, interventional radiologist, who I got him doing these cases, I called him up a few months later and I said, hey, how's it going? And he goes, oh, my staff hates these patients. These patients are nuts. They're crazy. And they're driving everybody crazy. And they call every 10 minutes. Oh, I called him back, several months later and I go, how's it going? He goes, oh, we love these patients. They're wonderful. The whole staff loves them. Well, what happened? You fix the veins on these patients and they go from crazy to calm because I think you're turning off their chronic fight or flight. Their adrenaline goes down, probably their cortisol goes down. This is what I think. And their sympathetic outburst goes down and they're calmer. We had one patient who was like a goth, angry girl who was yelling at her parents. And man, she came back in, she looked like a librarian. It just makes people calmer because I think it's turning off stuff that's giving people the symptoms of anxiety. And there's a study by Wagner that shows that if you take POTS patients, they don't who have these panic attacks, they're not anxious. So I started asking patients, did you ever have an anxiety or a panic attack and you weren't anxious? And I had several go, yes. Well, what is non-anxious anxiety? I never heard of that. Okay, that's a real thing. Hip pain. There were two studies that reported little case studies, like one and then two patients who had hip pain resolved. Wow, this really works. And it, I could tell you an amazing anecdote about a patient who came from Syria. Lovely, lovely couple. And she had had all these MRIs and seen doctors in all these countries. She had POTS and she had pelvic pain and she had horrible hip pain and a normal hip, and she had a big bundle of varicosities right against her acetabulum. We embolized those, they shrunk away, and her hip pain went away. And they were very, very grateful. So there's even a study out there that says that in patients who have sacroiliac pain, that somebody noticed that there are a lot of varicose veins seen in the picture in the pelvis of people who had sacroiliac pain. Well, you got Ehlers-Danlos syndrome or something, you're going to have painful joints, dislocations. So no one's going to figure this out, right? And furthermore, anybody who still has it, well, a lot of 56% of them have joint hypermobility, right? This is different. This is pain you can relieve by fixing veins. No orthopedic surgeons know this, so keep it to yourself. Migraines. Okay. So here's this is stunning. We had people that couldn't go to work, couldn't go outside. They had just a sort of mixed thing of maybe they got POTS or chronic fatigue, and they all have migraines. And so this is just what we found. At 3 and 6 months, you fix their veins and their migraines go away. Not everybody, but if you look at this, their migraine pain improved 3 point something, 3.2. But notice how that happened. All of these people who had the migraines of like 8, 9, and 10, almost all of them, a couple still stayed, but a lot of them get pushed over here. We had patients who they could go to work, they just get in their car and drive, and it's amazing. And somebody has duplicated this, and we're going to talk about it. Why? Brain fog. Yeah, pre-COVID brain fog. This isn't your, garden variety COVID brain fog. This is your pre-COVID brain fog. Brain fog really improved. First of all, I don't know, like a 1 to 10 scale. A lot of this stuff's just on a 1 to 10 scale, like it's pain, but this is brain fog. But it's confusion. The mean score for, I think the group was 6.5, and then afterwards 2.7. So the brain fog improved, I don't know, maybe, I don't know, it improved somewhat. Anyway, this is how much it improved. So we know that from all the stuff done by the physiology people, that people with chronic fatigue and brain fog got low blood flow in their brain. Okay. And here we open up some flow and their brain fog goes away. All right. So this is another weird, interesting thing. I don't think this is in our paper. So what I did here is I took the orthostatic hypertension quality of life thing, the validated thing, okay, and I looked at it before and after for each of the symptoms in that inventory. head and neck, discomfort, weakness, brain fog, vision changes, fatigue, and dizziness. Dizziness is the closest we get to passing out or syncope questions. But so these are our pelvic venous pain patients. This is the same survey used on extreme POTS patients at a tertiary mecca for POTS, okay? And they were treated, so these upper patients are treated with, I don't know, stent embolization, whatever, of their pelvic veins, right? And these patients are treated with getting a PICC line or a port and getting saline infusions because they're just desperate. So they were getting infusions maybe every week. I don't remember. And the result of this lower one, Rusia, is that it worked. And I think they were already treating patients. They just wanted to do a study and show that it worked. And it did work. Well, think about that. So look, here's my sister's handwriting. And this is the pelvic vein people. And I think everything improved 49%, and then their patient improved 47%. So guess what? If you think of it mechanistically, what are they trying to do? They're trying to fill up the patient's tank till they get blood up to their brain, right? Or heart. And then all the receptors that are triggering the fight or flight can calm down. And what are we doing? We're just trying to open up flow, like mechanically, like a plumber, right? I mean, you look at this, they look the same. And these are apples and oranges, right? These are pelvic congestion patients, and these are severe POTS patients. This is very striking. So my sister made this. So she made this just to look at these patients, and this is early on. So it says POTS symptoms we could call, but it's really the OHQ, and this is the puff. And then this is, I guess, whether they have this stuff. So if inside this ring is the patients with pelvic congestion syndrome or, pelvic venous pain, 5 patients are inside that ring, but ain't got none of this stuff. But you can see the distribution. I don't know if this is interesting, but 12 patients had everything. But so I think it's pretty interesting and just fuel for more research. With what we're doing, we can only go so far. So, and I am thrilled by this. I'm so happy by being at this meeting, let me tell you. Oh, so, but here's what I could do in this, okay? So I could take, to keep moving, you'd be around. Yeah, over here. So I could take these ICD-10 symptoms that we tracked on that same old questionnaire, and we could look at them and then bundle them together. So this is artificial, right? This isn't a patient. This is just me looking at these symptoms for a group. This is very artificial. So fatigue, muscle joint pain, low back pain, weakness, head or neck discomfort, prolonged recovery from exercise. That's, of course, very important. Now, for our patients, I had just read about it, and I realized that was the sine qua non, and I added it in, but we only had 7 out of 11 of our study, but you'll see it comes in the next study. So anyway, all this stuff, it's decreasing 50, 60%. P-values are good. And prolonged recovery from exercise, we just didn't have enough people. So that's pretty interesting. We can look at symptoms associated with POTS, brain fog, dizziness, sweating, seeing spots, heartbeat, anxiety attacks, heat intolerance, and skin sensitivity didn't do much. Heat intolerance, vision problem wasn't much. Most of the rest, like brain fog, dizziness, regular heartbeat, and anxiety attacks were they decreased quite a bit. And so we know POTS is blood flow and stuff. So again, this is very artificial, very artificial. It's just like, do our patients actually have these syndromes? And this is just a weird assay. So what about irritable bowel syndrome? So we had the Rome thing, but then I put in, because some patients didn't seem to understand it. I put in backup questions that seemed to go with irritable bowel syndrome, bloating, constipation, and diarrhea. Now, I had a chance to put chronic nausea and weight loss. There is something about weight loss and GERD, because I get patients that tell me their GERD is gone or better. And I'll bet Brooke has gotten those too. So, well, let's look at these irritable bowel things. Abdominal bloating, 47% better. Constipation, 51% better. Diarrhea, 70% better. I don't know if they were on some drugs that they stopped taking that were giving them diarrhea. I have no idea. So now we're going to jump up to the study that you see Brooke Spencer, prominent here because I think she probably did the most cases, presented by Grace Knutinen. And there she is at the Cardiovascular Interventional Radiology Society of Europe. And yes, this was it's the same frickin' questionnaire, okay? But this is prospective, goes out to there, I don't know, 5 or 6 different centers. And I didn't have anything to do with these patients. I never saw them or touched them. And that follows 59 patients for a year for all this stuff. And it did win the prize for best overall scientific presentation at the annual meeting of these vascular people. So that's they can't ignore it now, right? We'll see. So if you look at all of those surveys that made up this questionnaire, we had PUF, that's one I told you about, which is the interstitial cystitis one. And so at a year, they maintain improvement. They got pretty good with Rome. So the people with irritable bowel, 30% decrease from the baseline score. And there's the OHQ thing, and they're like, maybe 40, 35. And this is ancillary. These symptoms are just symptoms that you can add into other things to make syndromes. And they're just included for completeness sake. Here's the IPPS score. Remember, I told you the International Pelvic Pain Society doesn't believe in vein pain, but if you give patients their test, it improves. And then the bottom one is PCS score. That's just something I made up, just totally made up a basket of symptoms that I thought would be common in pelvic vein pain patients. And that should do better if we're doing the right thing. Wow. Well, this is pretty cool. So at a year, these results don't really degrade. They're pretty good, Well, this is the big one here for MECSF people. CFS, yes. Okay, so here's that validated thing. And this is that, remember, I had to cut, mine were just 3 and 6 months, then COVID, so I got nothing out here. So what if I'm just reporting happy stuff and it just all goes back because it's all placebo? Well, so here we are at a year and the other people doing it. Dizziness, lightheadedness, trouble concentrating, that's brain fog. Fatigue, that's pretty good, eh? Head and neck discomfort, just soreness, problems with vision, weakness is down here. Well, I had included this thing, prolonged recovery from exercise, which is, that's my version of PEM, but that was on another chart. So I grafted it onto this chart and here it is. that is the sine qua non for ME CFS. So if you put that in there, it helps put things in focus. So this is, it's hopeful. That's all I'm going to say. So I'm almost done here. Um, this is a cool study from, what is it, Guatemala. And this shows that these guys down in Guatemala had a whole bunch of patients with pelvic congestion syndrome. To get you guys out of the way here. Go back. Okay. And anyway, they had 123 patients who had migraines and pelvic congestion. They fixed the pelvic veins and the migraines resolved in 77%. Resolved, meaning they were cured of migraine, and improved in 87% at 6 months. So this is incredible. Migraine is the most common neurological condition in the world. There are 1 billion people with migraines, okay? All right. So should everybody with a migraine get this? That's not what I'm saying, of course. But this is amazing. You know, the gynecologists don't want to look for it. They're the gatekeeper for this. They have all these patients on a ranch, and you can't get in there to talk to the patients. So okay, finally, here's an article. This is an article by Dr. Gavrilov, and I think Ron Winokur told me about this stuff, but he's a very bright guy. I think he's a surgeon, but he looked at, so here's an important question. He looked at patients who had, abnormal pelvic veins and had pain, and another group of patients who had abnormal looking pelvic veins, but did not have pain. And so maybe we're dealing with maybe 40% of people that may have some big looking veins, well, which are the bad veins? I think so. What he found out was that in people who had the pain, and I would presume their veins are under more pressure and they're more distressed or inflamed, who knows what, they released more CGRP, which is calcitonin gene related peptide, and that, so you can just measure it, assay it in the blood, and if they got big veins and no pain, then they ain't got no CGRP. And then also looked at some other stuff, SP, which is substance P, and that's involved in all this as well. So this is very interesting. A lot of bright people in Russia, and so turns out they are trying to use monoclonal antibodies against CGRP in migraine. So there are receptors for substance P and CGRP in the trigeminal ganglion, for example. So it's pretty wild. But anyway, what about fibromyalgia? It does seem to get better. Muscle pain does get better in patients when you fix their veins. So I found this article, and it says that this is interesting. So in people, this keeps moving around. Okay, in people who have fibromyalgia, uh, they checked a lot of stuff that their CGRP, came out to 22 nanograms per milliliter, but the control group had 3. And then they checked all these receptors. So why do people have pain in their muscles in fibromyalgia? This stuff, CGRP and substance P, they're powerful vasodilators, like way more powerful than prostaglandins. And of course, I haven't said a word about histamine because you guys got a 9-hour lecture from Larry about that, and I can't add anything to that, and that's doing something as well. But this is pretty cool. Finally, we're going to talk just one more time about this article from Russia, and this is about these guys who took patients, young women who had interstitial cystitis diagnosis and enlarged veins in their pelvis. And they did this wild exam where they have controls and then they have, the chronic cystitis and pelvic vein enlarged patients. And then I think they embolized the veins. So they look what they did. They checked blood flow in all these veins. They did urodynamics. And then they used a laser device to measure microcirculation in the bladder wall. So my theory that I have is that the pelvic congestion, the high venous pressure, is making the bladder wall ischemic. And these guys in Siberia do this thing, and it's so amazing. Look at this, microperfusion units in the bladder wall in normals. In people, these women with the big pelvic veins, it's I don't know, what is that, a third? I'm bad at math. And after you fix their pelvic veins by embolization, boom, goes up to normal again. Wow. And then they looked at, you know, the veins, speed of blood flow, and how normal it's 4 to maybe 7. And then it goes in these people, it's down to 1.6. Actually, very, very slow flow. After treatment, it goes up. So, geez, and their urodynamics go from terrible to normal. So at least in young women, fixing pelvic veins and measuring everything can make them normal. Now, I don't know if this would work in an old lady with a shriveled up, scarred down bladder, but this is amazing stuff because this ruins people's lives, I'm telling you. So here's what I think is going on. I think that this is chronic fight or flight, a chronic emergency. And that means, it's at the expense of rest and digest. So if you look at all this stuff that happens, muscles get tense, heart pumps faster, chest pain, palpitations, sweating, muscles tense, breathing fast and shallow, hyperventilation, oxygen needed for muscles. Yeah. You also need to shove blood into your central organs with hypocapnia. Brain gets body ready for action. You're anxious, adrenaline, fight or flight, blood pressure rises unless you can't get no blood up there. And this stuff happens, digestion slows or ceases. That's irritable bowel. And cortisol is released, which depresses the immune system. Well, it doesn't do anything to the immune system if you just have to have a little emergency. But what if every day is an emergency? Would that make your immune system all tapped out? I'm just asking. All right, so we're almost done here. So here's the way I look at it. This is just somebody will tell me where I made a mistake either now or later. So normal, you stand up, got some orthostatic stress, little decreased blood flow to the thorax, just decreased stretch of the receptors, and the receptors are in the vena cava and in the right heart, I think. Oh yeah, that's what I said. And so that will increase sympathetic drive, a little norepinephrine. That should raise your blood pressure. So that's normal. So now blood return is impeded. Pelvic varicose veins, iliac vein blockage, EDS, making everything stretchy. It gives you pelvic venous pain, interstitial cystitis, non-bacterial prostatitis. If you're a man, bladder pain syndrome, low back pain, which has been noted all along with these pelvic veins, vulvodynia, absolutely. Leg edema, acrocyanosis, blah, 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 and hip pain, okay, venogenic hip pain. So what I'm saying is now, if that makes everything worse, you're going to go into fight or flight. your little sympathetic bump up turns into, we need more, we need more. You're going to get sympathetic excess at the expense of rest and digest. So that I'm telling you, it could somehow give you irritable bowel syndrome. I think that this can trigger histamine and MCAS. I'm not sure. A lot of other things can trigger it, but that also causes vasodilation. So that might feed into it even more and make everything worse. And we know that histamine and stuff can feed into bowel problems. I put this arrow here. I really don't know what I'm talking about. So tachycardia, anxiety, hyperhidrosis, POTS-like stuff. That's what I think. Muscle cramping and fibromyalgia, or maybe CGRP. And tachypnea and hypocapnia, arterial vasoconstriction. Okay. So that is going to further decrease cerebral blood flow and give you even worse fatigue. And, maybe a picture of, ME, CSF. And then, syncope, if we have some added vagal stuff or whatever, you may get syncope. And of course, these people actually become dehydrated when they have their, as Peter Rowe told us. So the other thing is this: distressed pelvic veins apparently emit CGRP and substance P. Not apparently, they do. I mean, I assume they do, because people who have high CGRP and abnormal veins have those veins are causing pain. So is CGRP coming out of those distressed veins as a signal of pain? I don't know, but I think so. And, Big Pharma is developing CGRP blockers. They have them to try and fix migraines. I don't know if they're so great yet. This is the way I think of it. Okay. Okay, I'm done. That's it. Comments, please.
Well, first of all, thank you very much. This was very, very good. Very thought-provoking, and we have tons of questions. Hopefully, we will continue on these topics in our own chats and emails firing back and forth. And we so appreciate you. Thank you so much.
All love to everybody and good luck to everyone.
All right. Thank you.